Hello, and welcome to Health Information. My name is Lynn Reveneau, and we're going to be talking about stroke today. And we have with us Dr. Steven Spardella, who is Chief of Emergency Medicine at Hallmark Health. And is that at both hospitals?
That's at both hospitals, yes.
And you've been there how long?
14 or 15 years.
Wow, a long time. And you mentioned when we were talking earlier that that the hospitals both hospitals, I assume, are designated primary stroke centers.
Yes.
What does that mean?
Well, what that means is the state of Massachusetts about 5 or 6 years ago decided to try to standardize how we diagnose and treat stroke across the state, which pretty much coincides with the movement across the country. And what that means for us is it's a point of entry system, which means when people are having a stroke, we have to be able to diagnose and initiate treatment for that stroke in the emergency department within certain time limits. Essentially what that means is when someone arrives to our door, we have to be able to diagnose the type of stroke, if they're having a stroke and the type of stroke they're having within 25 minutes and have the initial treatment available in the next 25 minutes and complete it within the first hour of arrival. And if there is extensive stroke damage to someone, then we have to make arrangements to transfer that patient into a tertiary care center in Boston. And pretty much every hospital, most hospitals in Massachusetts are primary stroke centers right now.
The emergency room.
The emergency departments, yeah.
And the problem that the reason this is important and why we're talking today is because you and other people who do what you do have figured out that there's a gap somehow between what you would like to see in patient response.
Absolutely.
And reality.
Yep, there is a gap. What we've done from our research over the 4 years is we know that when people do arrive to our door, we're very good at doing the diagnostic, figuring out there is a stroke and initiating the treatment. But what we found in our area is that there is a great delay in people arriving to the emergency department for us to diagnose a stroke. In fact, in our area, in our catchment area, people seem to take the longest compared to most other areas in Massachusetts for some reason. So we're on a campaign to educate people about stroke and what we can do and what their hospital can do, what both hospitals can do in our catchment area, and hopefully improve people's understanding and what they should do when they have symptoms of a stroke.
Because it will improve their outcome.
Oh, absolutely.
Huge.
We live within a 3-hour window, and that's not an awful lot of time. And what that means is what we hope for and what we're trying to accomplish is we would like people to understand what we're looking for when they have symptoms of a stroke and make it to the hospital so we can intervene within that 3 hours. And that's not an awful lot of time.
And why is that? What is this magic 3 hours about?
Well, the 3 hours is, what the current research is we have available to us, it's a medication called TPA, and people know it as a clot buster. It's been utilized probably over 12 years for other conditions. It initially was utilized for heart attacks. In the last probably 10 years, 8 years, it's been a little controversial, but it's accepted more that's being used for strokes, which are now being called brain attacks. And the 3-hour window is based on the fact that the potential complications from the medicine increase dramatically if a person receives that medication after 3 hours. So like anything else, the sooner you get it, the better. And the longer window, the longer time it takes to get the medicine, the greater chance there's going to be complication. And that complication is bleeding.
So it's not just the fact, one would think, is the sooner you get the medicine, the more quickly you get the brain its blood supply, the less damage is done. But it's even more than that. It's complication rate.
It's more than that. You're absolutely right. You know, the quicker we can open up the clot and restore the blood flow and the normal functioning of the brain, the better chance we have to save brain tissue. But absolutely there is a dramatic increase in the complication rate after 3 hours. In fact, what we found on the first part of that in terms of saving brain tissue is through MRI, now we can actually find that there are areas of the brain. We used to think that once someone had a stroke,
the brain died.
The brain died.
That part.
Yeah, that part. But what we know now is there is a area of the brain in the area of the stroke that if we do, it's not dead yet. We know that now because technology has allowed us to visualize that. That if we can restore the blood supply and flow to that area, we can save that tissue, potentially save that tissue. It's absolutely not successful all the time, but there is that window, and we can potentially reverse or minimize the effects of stroke. That 3-hour window is very important.
So you're trying to move people into the hospital faster so that you can accomplish this perfect
Absolutely.
outcome.
What we found
best possible outcome.
Exactly. What we found in our area is we found that people wait almost 8 to 10 hours to come into the emergency department because they're not convinced they're having a stroke. Most people think that a stroke is where you lose complete function of part of your body, and absolutely that could be it. But there are a lot of other subtle symptoms that people can have that could turn out to be a stroke. Not always, but could be. And in this area, for some reason, people wait it out. We found that people tend to not use 911 in this area to come to the hospital.
They're
I'm not
embarrassed?
Sure why. I'm not really sure if they're embarrassed or they just don't want to bother.
Don't want to bother anyone.
Yeah, exactly.
That's a
they want someone
New
to
England
drive
thing.
them. They want a friend or a family member to drive them to the hospital. They want to see if whatever they're feeling goes away by the next day.
That's probably under the heading wishful thinking.
Absolutely. It could happen, but wishful thinking, because again, you're outside that. If it is a stroke, you're outside that window.
I remember in the 70s and the 80s going through this same process with heart attack.
Oh, absolutely.
Don't be home having, Tums
Oh, absolutely.
and a nap when you could be in the hospital getting
Absolutely.
saved.
And it took decades to educate people to just come to the hospital. And
It's like we're seeing the same thing. We don't.
absolutely. Stroke is
Frustrating.
stroke has sort of taken over the years, has taken a back seat to heart attacks in all the treatment and technologies. But it's a frontier that medicine is really jumping into right now, and that's why we're pushing for people to try to understand what's going on and not feel like they're bothering the system.
In fact, the system would be grateful
Oh, absolutely.
if you'd come in early and give them an easier job.
Absolutely. It's not even that it's easier. It's frustrating when we know we could have done
only
something or
come
potentially done something if you just came earlier. Why did you wait? I mean, we don't ask people that because that's a tough question.
Spilt milk.
It's, exactly. But
But so trying to get people to know why it's valuable to come in early is the point here.
Absolutely.
And then we need to figure out what are those clues. Now, before we do that, though, let's just say, what is a stroke? What is a shock? What is a brain attack? And figure out.
They're all terms for the same process. The word shock is sort of a generational word that people have used over the years. I've taken a shock. That's a stroke. A stroke, essentially, there are two kinds of strokes. Some people, there are three, essentially. The two that are most common is either that the blood supply to the brain, and blood feeds the brain, is blocked. It's cut off for some reason. There's a big clot that stops the blood flow. The other type of stroke is if there's bleeding in the brain. Essentially, both those situations lead to a situation in the brain where it's just not being fed what it needs to fed, and the tissue dies quickly. It loses function, dies quickly. The other type of stroke is what people refer to as a mini stroke. We call it a TIA, which is a transient ischemic attack. Mini stroke probably is the more common expression. And essentially, it's the exact same thing as a stroke, but all the symptoms of the stroke go away, and people return back to their baseline or back to their normal within 24 hours.
But that's a very important thing because it tells you that probably something is not working perfectly in terms of circulation.
Absolutely.
So it's not something to say, oh, phew, I'm fine now.
Oh, absolutely.
But rather, this is a clue, I'm lucky. It's like people with a heart attack getting chest pain before they drop dead. They're lucky because they got a warning.
If you look at it with a positive spin, it's a warning sign. And then you would hope people would follow through. The other piece of that is sometimes people wait and think that this will go away.
The
You
next
know, it's
time.
something small, this will go away, I'll be okay. And it might, but it might not. You know, so when you think of it, a mini stroke symptoms can last 24 hours. But we need people in the first 2 or 3 hours to come to the hospital.
And you don't really
It's-
know the end of the story.
You don't know. You don't know.
So better
And-
safe
and
than sorry.
Absolutely. In fact, the treatment for mini strokes is changing dramatically now, too. They're being treated much more aggressively. So either way, what we're looking for are people to accept the fact that something's going on. And there are certain symptoms that we try to
Yes.
educate the population with, so that are more common. I mean, there are a slew of symptoms, but the more common, what we're looking for, if people can understand the 3 or 4 symptoms that are most common and say, this is going on, I think I need to be checked. And essentially what those are in fact, the state puts out this program called FAST, F-A-S-T, and we're using that program to try to educate our population. And the F of F-A-S-T is something going on with your face. Part of your face isn't working.
By that, you could mean lips, tongue,
Lips,
speech
tongue,
problems,
it could be drooping,
visual.
anything on your face that seems asymmetric, which essentially means one side is not functioning the same or feeling the same as the other side. The A is it should be A, and it means arm, but it also should be leg, where one of their extremities isn't functioning the way that you think it should. And it doesn't necessarily mean complete loss of function. It could just mean something as simple as, you know, you're right-handed and you go to pick up a cup and you just can't do it. And something you would normally say, that's odd. Well, if you get to that point, that's when you need to be checked. And the same thing with your non-dominant hand, your left hand, if you're right-handed. People still do things. Essentially what we want to say is, in terms of people's arms, are, if it's not functioning, if it just seems different and it's not functioning the way you expect it to, that's a stroke until proven otherwise. And the same thing with your legs. If you're just not walking or your balance is off because one side is not functioning similar to the other, or whatever your baseline is, then that's a stroke until proven otherwise. And then lastly, the S is speech. People can have a difficult time speaking. And it doesn't necessarily mean you've lost your speech. It could just mean that your speech is thick. You just can't get the words out. You know what you want to say, but what's coming out just isn't right. That's a stroke until proven otherwise. And then the last T of FAST is telephone. The state, we're buying into this, our educational process also, is people need to use the telephone to call 911. So that's the program. So essentially when we talk about the symptoms, again, trying to narrow it down, and again, it could be anything. But the more common, if we can get people just to buy into the more common of asymmetry of your body, speech difficulty, or your face isn't functioning the way it should be, then that's when you call 911. And what we're really pushing for, in fact, we're starting a program in Hallmark, we're just starting it now, called Watch Over Me, is people, it's not the person having the stroke necessarily who's going to know they're having a stroke, it's the people around them. We feel we need to educate people around people